Welcome to episode 3 of our expert interview series. Today, NHS respiratory consultant and fellow long hauler Dr Asad Khan takes on the mantle, talking to Dr Ben Marsh about activity management, fatigue and post-exertional malaise. Now, the similarities of long COVID with ME and CFS have been quite a controversial topic, with many in the long COVID community not wanting to be labelled or to have the same stigma that's affected those suffering from ME and CFS. But it's my belief that it's a very similar mechanism of disease that affects both groups. Yes, long COVID may throw out all kinds of extra complications and extra pathologies on top, but I'd wager that the vast majority of long haulers are suffering some degree of the same pathophysiological processes and thus many of the same symptoms. It would be incredibly short-sighted of us then to not listen to those who've got decades of experience of dealing with a condition we can learn a huge amount from. It's a long film, but there's so much good stuff here, well worth watching in chunks if it helps you get through it. So over to Dr. Khan.
So welcome, Dr. Marsh. Good morning. So perhaps you could just start off by telling us what your life was like before you got the illness.
Yeah, so before I became unwell, I was burning the candle at both ends and in the middle, really, and having a great time doing it. I worked as a consultant paediatrician and clinical director for my department in a large city NHS trust. Commuted to from work, was very much into my fitness, ran half marathons to relax, had 2 young kids, or have 2 young kids, and yeah, just sort of lived a good social life. Yeah, all was good.
Right, so clearly quite high performing, high achieving. When did it all change?
Back in 2015 first, I developed a sort of viral pericarditis, viral heart infection, just out of the blue. I was running just a few days beforehand, and then became very unwell while at work. That then persisted, returned, kept recurring for about 6 months or so. I was able to get back to work for about a year before having a further relapse and then subsequently becoming much more unwell and developing more prolonged chronic and overwhelming symptoms.
Okay, so what happened in that year when you were back at work? Were you working at your previous capacity?
I was, yeah, probably above my previous capacity, really. We worked very hard to make things more efficient so that my work level would be better, but I, in hindsight, ended up taking on as much, if not more, than I was doing beforehand, really.
I see. Do you think that was a mistake?
I think that's difficult to say. One can't go back in time. I'm not a great believer in hindsight. I certainly never received any advice or guidance against doing that. So I think that's impossible to say.
Okay. And once you became unwell again, what happened?
So I developed a cluster of really quite significant symptoms. Extreme, overwhelming fatigue, headaches, couldn't focus or concentrate, lost over a stone in weight, what we call dysautonomia, so couldn't control my body temperature, and just was really, really very unwell, to the point that I was extensively screened for cancer, for Lyme disease, HIV. I had a huge amount of screening done because I was so unwell. There was a great deal of concern as to what the underlying process was.
I see. And then what was the end result of all that?
Well, the end result was that that cancer was ruled out, as were the sort of infection screening for the sort of common nasty viruses. And the conclusion was, at this time, we can't identify a significant treatable cause. And the conclusion was a post-viral syndrome, very much of the sort of severe nature, summarized as ME, or chronic fatigue syndrome, effectively a post-viral syndrome.
Okay. And since then, how has it affected you?
Well, unfortunately, those symptoms in their majority have remained. I am effectively significantly disabled by them, in terms of largely housebound. I can't focus or concentrate for really any period of time. In terms of, I can't really read more than a few paragraphs. I can't focus, concentrate, follow instructions particularly easily. Physically, I'm limited as to what I can do, as well as having very little temperature control, either excessively cold or sweaty. I have postural symptoms, so I faint, I can feel very lightheaded, and really, as I say, very limited, very disabled by the symptoms. And any exertion, whether it be physical, mental, or even emotional, can cause, there's a significant cost to that. So if I am undertaking anything, then I have to prepare for it, rest beforehand, and expect payoff afterwards.
I see.
So, for example, talking to you today, I've obviously rested beforehand, and expect to experience significant fatigue, headache, migraines afterwards, which could last for 2 to 3 days, if not longer, afterwards.
Dr. Marsh, it's really good of you to agree to do this interview, despite knowing that risk.
Well, I think it's very important to me to share awareness of the true nature of this condition, of post-viral syndromes. I think too often they are dismissed, ignored, neglected, and having the opportunity to discuss and share the impact is very important. It's I think it's also important to understand that quite often, if I see friends or which is very limited now, but if I do see people, they obviously see me at my absolute best and don't see the payoff that comes afterwards. So I think raising that profile and awareness is very important to me.
Ben, I couldn't identify more with that, because I have exactly the same experience. So like you, I have a chronic post-viral illness, i.e. long COVID. I experience fatigue, I experience dysautonomia as well. And I have a bit of a public profile. I have been doing media. I have been quite vocal about the condition in terms of raising awareness of it, and also of the services that aren't available to us that should be. And it does come at a cost. And I pay for it afterwards by sometimes spending several days in bed. And that's what people don't see.
Yeah.
And what they see is this person who is articulate, is coherent, who goes on television, and is able to express themselves in quite clear, concise terms. They don't see the preparation, they don't see the aftermath. If only they could.
Well, yeah, indeed, absolutely.
So you touched on dysautonomia, and like I mentioned, I experienced that as well. I have quite severe POT syndrome. One of the things that I have noticed is that there is a reluctance amongst the long COVID community to draw any parallels with MECFS or to associate with advocacy groups or organizations representing MECFS. Some of the arguments that they use are, well, MECFS is fatigue, whereas long COVID is heterogeneous, and there are various organ pathologies, end organ damage in long COVID, so the two diseases are different. One of the other arguments that they use is that, well, MECFS have an established lobby, so it doesn't make sense to join forces. Thirdly, there is a concern which I don't think can be dismissed, that unfortunately MECFS has had this label of being psychosomatic applied to it by the medical profession and by policymakers. And there is a worry that we may be forced into the same corner. What's your response to that?
ME, or chronic fatigue syndrome, as it was named many years ago, does have a history of controversy associated with it as an illness, as a condition, and I think that's obviously unfortunate, but hopefully we can sort of move beyond that, because certainly in my experience and the people that I've spoken to within both the ME community, but also a number of people, including yourself, within the sort of evolving and newly formed sort of long COVID community, is that certainly in my experience, the efforts by those of us within the sort of MECFS advocacy community who are reaching out, trying to help and support people within the long COVID community, the motivation behind that is to help to try and avoid and prevent what we've experienced happening to your community as well. The reason for reaching out is one of help and support, not hanging on to coattails or trying to benefit from it or anything like that. The fact that a number of the major ME charities have produced huge numbers of resources to try and help and support people with long COVID, including the ME Association, Action for ME, ME Action, have all produced extensive resources to try and help and support. The way I see it is that approximately 70 to 80% of patients with diagnosed ME, the mechanism is a post-viral illness, a post-viral syndrome, which is then where the symptoms, the features are very prolonged and reach the criteria. Yes, COVID-19 is a new virus, but it is still a virus. The fact that the previous incarnation of SARS-CoV caused ME-like illness, and there's no reason why this virus, by COVID-19, wouldn't do the same. I think it's been identified that there are a number of different subgroups within so-called long COVID. There are those who have direct organ damage from the virus, heart, brain, kidneys, lungs. There are those who have post-intensive care needs that for whatever reason, if you're intubated or cared for on intensive care, you have health needs and rehab needs. But there is clearly a large subgroup, often those not initially very unwell, who then develop this post-viral fatigue syndrome, which, as potentially describing my symptoms, and I know you recognize much of what I experience in yourself. And I think it's that cohort where there are significant overlaps and where there could be the most benefit in terms of awareness, in terms of research, identifying causes and mechanisms, and hopefully treatment and support moving forward. Just finally, you mentioned about people with long COVID saying it's much more than fatigue. And I think that's where the name chronic fatigue syndrome is such a terrible name, because as I've just detailed, it is so much more than fatigue. And the fatigue is overwhelming. I've run marathons, I've done weeks of night shifts and done stuff during the day. I've burnt the candle at all three ends, and I have never felt such overwhelming fatigue as this, as well as the other symptoms that go with it. So I think, as I say, it's to think that chronic fatigue syndrome, ME, is just fatigue is wrong. And I think hopefully by discussing the other features and symptoms, there will be people with long COVID that recognize those and realize that that there are significant overlaps. And I think a lot to be learnt either way between the two communities.
Yes, I have to say I agree with you 100%. Certainly the phenotype that you described of the fatigue, of the worsening of symptoms after exertion, the presence of dysautonomia, presence of MECFS, those are things that are all common between the two conditions, and a lot more than that as well. So I think collaboration can only be beneficial because, as you said, post-viral illnesses just haven't had the research put into them in terms of understanding the mechanisms and potential treatment targets. And hopefully this can provide us with the opportunity to do so. So I would certainly welcome any collaboration. So we've touched upon the worsening of symptoms following exertion, whether that's physical, mental, or psychological. And certainly that's something that resonates with me, as well as many other long COVID sufferers who do experience post-exertional malaise or post-exertional symptom exacerbation. Now, there is little guidance out there as to how to manage fatigue in long COVID, and certainly very little about how to avoid or whether to avoid PEM. In fact, there are videos circulating of certain, shall we say, CFS practitioners advising long COVID patients to push through their symptoms and to exercise. Certainly the experience that I have had, and a lot of other sufferers have had, is that that is not beneficial. It doesn't work. It can actually be harmful. Your opinion on that?
Yeah, I think it's an interesting concept, because it's one that's very, very difficult to understand for health professionals as well as the general public. So what's called post-exertional malaise or post-exertional symptom exacerbation is the defining feature of ME, chronic fatigue syndrome. And effectively, it's where due to exertion, whether that be physical, mental, even emotional exertion, can bring on significant fatigue, cognitive disturbance, debilitating symptoms, in many ways akin to actually having the original illness, the original symptoms. So the way I try to describe it to others is most people, the large majority of people, have had a nasty flu-like illness, and with the malaise, the ache, the headaches, really nasty sort of viral symptoms. And just the act of exertion, as I say, whether that be physical, mental, or even emotional, can bring on those symptoms. And sometimes even delayed 24, 48 hours, even 72 hours afterwards, you'll experience those symptoms as a result of the initial exertion. And that those symptoms can then persist for hours, days, even months afterwards. And this is where the misunderstanding comes, because normally, let's say if you live quite a sedentary life and you decide one day, let's go on a long walk, and you go on a long walk, and afterwards, even the next day, one might feel tired, achy, and that sort of, everyone's done it. The key difference is that having experienced those fatigue symptoms, somebody without PEM would then the next day or day after feel better. And the next time they went for a walk would be fitter and stronger. Or if it was cognitive exertion, they would be brighter, be able to do the test more easily. So yes, after exertion, one feels fatigue and perhaps rests, but then you get stronger and fitter and better at it if you keep going. And that's the standard rehab approach for lots and lots of illnesses, everything from a sprained ankle to a hip, to a stroke, to a heart attack. That advice to gradually increase, to work through fatigue, is the standard rehab model. But, and this is the but, there is a cohort of people, believed to be about 10 to 20%, who have a serious post-viral syndrome where they will have an abnormal reaction, an abnormal physiological process in their body, thought to be inflammatory, possibly in nature, and still being investigated as to the exact cause, where their response to exertion is not a short period of fatigue and then improvement and improved fitness. This group, this cohort, who are defined as having ME, chronic fatigue, and a proportion of those with long COVID, they have an abnormal response to exercise. So their fatigue is abnormal. It is often way out of proportion to the exertion that they actually had. It comes with all the other features that I discussed: the fatigue, the debilitating malaise, headaches, and it doesn't lead to an improvement in fitness. If anything, it leads to a deterioration of fitness. And it's so important. If I could share one thing And I think the majority of people with ME trying to interact with the long COVID community, if they could share one thing, it would be that those telling people to gradually increase exercise must be aware to screen for that cohort, that 10-20%, where exercise and rehab will make them worse. That group need to rest and pace their activity gradually, to not overexert themselves, to be aware of what triggers the post-exertional malaise, and to pace and balance their life around avoiding it. Because it can, recent surveys have demonstrated 70-80% of people with ME who've undertaken this graded exercise therapy have been made worse. And I can happily provide references for all these statistics I'm throwing out, and I know I've shared many of them with you, Asad, outside of this conversation. So that's the thinking around post-exertional malaise. It must be screened for, it must be watched for. This idea that gradually increasing exercise will cure everything is not necessarily the case.
I see. And it's interesting, isn't it, that the forthcoming iteration of the NICE guidance on MECFS has taken out graded exercise therapy for that very reason.
Yes, yeah, and that's the draft NICE guidelines for ME was released in December. The full final guidelines have been delayed from April, but are hoped for in August. And certainly those guidelines do remove the use of a forced graded exercise therapy, GET, or GET for short, because the evidence previously used to support its use has been downgraded to the point where those recommendations have been removed from the forthcoming NICE guidelines, with much more of an emphasis on pacing, being aware of these symptoms, avoiding them, and gradually pacing one's energy usage, watching out for exertional malaise.
I see. Is there a feeling, or is there evidence to suggest that where people have engaged in graded exercise therapy without due consideration being given to the presence of PEM, their final outcome in terms of their disease severity and disability is worse?
There is a extensive survey undertaken by the I can't remember exactly who by now, which of the ME charities it was, but yeah, there is, and I can certainly share that reference with you, demonstrating that in this cohort of post-viral fatigue, that undertaking of sort of forced graded exercise therapy has not only worsened but prolonged their symptoms. And there's a number of both personal examples, but also on a wider population-based feedback showing that forced graded exercise therapy has worsened people's symptoms and prolonged their suffering.
It's definitely some lessons in there for us. You mentioned pacing, and I think there's probably a very poor understanding of the concept, and I certainly struggle with it at times. I guess it's going to mean different things to different people, but in your case, how do you implement pacing?
Pacing is a difficult concept to, well, it's an easy concept to understand. It's a difficult concept to, in my experience at least, to put into practice. There are different levels of how engaged one is with pacing. Some people, it's about understanding at what level of activity they can maintain, but at what level of activity they can avoid or minimize the post-exertional malaise, and just having an understanding of that and trying to avoid those situations. Then at the other end, there are people I know who use step counters or heart rate monitors and establish at what level they have to stay below to avoid post-exertional malaise. There's very, very good advice. I know the ME Association have a very good guidance on pacing. In essence, it's about keeping an activity and symptom diary and then tracing back to identify what might have triggered a particular period of illness, a period of post-exertional malaise, and then looking at that and seeing how it can be moderated, changed to try and avoid that in future. I know that some prominent people have rubbished the idea of pacing because it means that you focus on symptoms and you're always thinking about your symptoms and your activity level. But I think the counter to that is that by pacing right from the word go of experiencing a viral illness, understanding what your energy envelope is, how many spoons of energy is another phrase that's often used, you have, and how you can use those to then prevent a worsening of the symptoms down the line and also avoid the post-exertional malaise, with the understanding that there is a cohort that will deteriorate and will worsen if they keep driving on and experiencing post-exertional malaise. I've been trying to pace for a long time now. Sometimes I get it right, sometimes I get it wrong. Sometimes I'm aware, like with this interview, that I will go above my threshold and will need to rest and will experience payoff after it, but in this instance, it's worth it, I hope.
Once again, Ben, I can't express enough the gratitude that I have towards you for agreeing to do this. So, Ben, you have in previous discussions with me mentioned that there are ways of objectively identifying those patients who are going to experience post-exertional malaise because there are certain changes in physiological variables that can be measured. Could you perhaps elaborate on that?
Yes, I think it's very easy to dismiss what we've been talking about, to dismiss, and I know that unfortunately many of our medical colleagues have and do dismiss the concept of post-exertional malaise. But I think the good news in that regard is that there is a growing body of evidence, research evidence, showing the phenomenon of post-exertional malaise, of post-exertional worsening of symptoms and of physiological parameters. For example, there's a group, the Harvard ME CFS collaboration, which I would encourage everyone to explore, is a group of researchers based all over the world who are exploring using cardiopulmonary exercise testing, using even invasive testing to demonstrate that there are physiological changes in patients who experience post-exertional malaise, those with ME, compared to the normal population. At this time, those studies are experimental, i.e. can't be used yet to test the population, but they do demonstrate clear deterioration in this group compared to the normal population. They have shown that, for example, they've shown if you take a person without these post-viral syndromes, without ME, and you undertake an exercise test, if you then repeat that test in 1 to 2 days, their scores will improve, i.e. they have got fitter. So by doing the exercise, their scores have improved. They have got fitter. But if you do the same studies in patients with ME or chronic fatigue syndrome, that their scores will deteriorate. So even previously fit people will undertake the exercise test, but their scores will worsen, i.e. they are reacting to exercise differently. They've done the same with cognitive studies. So someone will undertake a maths test, let's say, or a cognitive test. You repeat that test subsequently, their scores improve. If it's done in patients with ME, their scores deteriorate, i.e. there is a process going on that means a reaction to exertion is one of deterioration, is one of a immunological mediated potentially process where your fatigue levels, your performance deteriorates. There's studies demonstrating, I could go on all day, but there's studies demonstrating if you take the plasma from somebody with MECFS and put it into a normal person, that their muscle reaction and performance deteriorates. You know, there is clearly a physiologically demonstrated process going on here. There is research to try and identify it. And my hope is that with the increased awareness and profile and research funding coming towards trying to help people with long COVID, that they don't try and reinvent the wheel, that they do learn from and take on this research which has been undertaken in other post-viral syndromes. And I know that those research groups are looking at long COVID as well. I think soon it will be very clear and testable for, hopefully, to demonstrate this cohort so that their rehab and activity management can be tailored to try and avoid the deterioration that many of us with MECFS have experienced.
Thank you very much. I mean, it's quite clear, isn't it, that MECFS is a 100% organic illness, and that there are indeed undeniable parallels between MECFS and long COVID, and there is a group within long COVID that behaves exactly like the MECFS population. And what you said about the need for biomedical research to identify the mechanisms underpinning the symptoms, and also towards developing treatments tailored towards those targets. It couldn't be more pressing, could it?
Absolutely. And also that those who are engaging in trying to help and support people with long COVID are aware of these things to look out for, are aware of these things to screen for, and are aware that of the impact of experiencing these symptoms can have, and how, yes, psychology support has a role, but its role is to help people to learn and adapt to a change of circumstance and dealing with these symptoms. It's not curative, it's to help and support.
And that's key, isn't it? Where CBT, cognitive behavioral therapy, has been promoted as a treatment for the illness. But what's probably more accurate is that, as in the case of many chronic illnesses, the role of psychological therapies is supportive in terms of helping the patient deal with the illness. It doesn't alter the illness itself.
Yes, absolutely. And anyone with any chronic illness needs help and support to try and cope with that, to adapt, to try and manage that. But as I say, the CBT is not going to cure a biomedical illness.
Well, Ben, I think we have taken a lot of your time, and I do hope that you don't pay too dearly for your efforts. Once again, on behalf of myself, Jez Bedinger, and the people with long COVID who will be viewing this interview, and the wider long COVID community as well, I thank you for your time.
Oh, that's very kind, Asad, and thank you for everything you're doing.
Hope you enjoyed that deep dive into the subject, and a huge thanks to Dr. Khan for filling in for me. Next up, we're going to be speaking to one of the world's leading experts in dysautonomia, Dr. Svetlana Blitzstein. Dysautonomia is a condition that your GP may not necessarily know much about, but it's probably responsible for a bunch, if not the majority, of your long COVID symptoms. Till next time.